வா 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 அக்கா பிச்சு 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 நீ படி 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 வந்து
எழுந்திரிச்சு உட்காடுறான், க்ரீப்பிங் பண்ணுறான், க்ராலிங் பண்ணுறான்.
பெனிஃபிட்டாக இருக்குங்களா?
ஆமாம்.
திருப்பி எப்போ வர போகிறீங்க சக்தி?
நெக்ஸ்ட் வீக். எப்படி மசில் பண்ணுவீங்க?
Like movements are free, hands and legs movement are free. He's active after that.
Okay.
Feeling good now.
Feel good. Is walking?
Yeah, he can hold something and walk. Not alone, but
Okay.
something like a cot, chair and everything.
உங்கள் பேர் என்ன? ஸ்விம்மிங் எப்படி பண்ணுவீங்க? சூப்பர்.
நிறைய டிஃப்ரென்ஸ் இருக்குது. ஏன்னா ஹெல்த் வைஸாக வந்து அடிக்கடி போகும், காஃப் அது மாதிரி இருந்துகிட்டே இருக்கும். ஸ்விம்மிங் போகிறதுனால அதெல்லாம் கொஞ்சம் கண்ட்ரோல் ஆகிருக்கு. தென் வந்து வாக் பண்ணாமல் இருந்தால் ரொம்ப நாளாக ஸ்விம்மிங் வந்ததுக்கப்புறமா தான் கொஞ்சம் ஸ்டாமினா வந்தது. நம்ம வாக் பண்ண ஆரம்பிச்சிருக்கா, நல்லாவே வாக் பண்ணுறான்.
After swimming,
I think in the interest of time, we will move on to questions.
climbing up,
If anyone has any questions, you can ask. Maybe a couple of questions, please. Yes?
Yes, ma'am.
Okay.
From 6 months. Yeah. A swimming coach can't do this. This is fully assisted by a physical therapist. So you have to talk to a physical therapist regarding this.
No. I think you have to standardize the protocol and teach other physical therapists also to follow in the rest of the country.
Sure.
Because one area develops an expertise and then it should be standardized first of all, and then all the safety precautions and whatever experiences you had. So what are the pluses and minuses of it, and then remove all the minuses and then concentrate on your pluses, standardize the protocol, and then contact other therapists in other places who are interested in learning, and then maybe you can do some online courses also, not that people have to travel all the way down. And maybe we can plan some online courses for physical therapists who are interested. Yes. Yes. Yeah.
Yeah.
See, even swimming, I think it will improve the lung capacity.
Capacity and
No, but then it improves definitely the breathing and the lung capacity. So I think it will set off the number of infections. I think one mother was also referring to that the number of infections were much less after she came to aquatherapy. So it is the reverse of what we think actually.
so that's exactly why we started with a younger group. The earlier you start, the better they are, because that's exactly what we want. We want to make their life better, improve the quality of their life. So that's exactly the intention
Yeah.
behind this.
Thank you very much for the wonderful effort. Yeah. Temperature of the water, yeah. And also the cleanliness, of course. Yeah. Yeah, hygiene and the temperature. Yes. Yeah. Yeah. Yes. Yes. Yeah. Just now they have started. I think things will get standardized. By the next conference, we'll have more aquatherapy centers in the country. Yeah, right. So thank you and congratulations. And then give them a big hand of applause. Yeah. Really doing something really great. Yeah. Then call upon Dr. Ruma Raha Chowdhury And she has done a study on genes involved in the innate immunity and inflammation as a major determinant of Down syndrome dementia. Over to you, ma'am.
Good afternoon. And first of all, I like to thanks to give me opportunity so I can come here and share my work with you. So my talk, I'm trying to try to make it a little bit simpler. So some of the things what I'm going to show you is it a very recent findings, and maybe sometime people will worry what you are telling. But what I'm going to show you, they are real research which is from our team and somewhere else. Oh, that one, okay, that's great. So last 2 days, you heard enough about Down syndrome due to trisomy 21. And trisomy 21 is because we have one chromosome. Yeah, so you can see I put the red arrow to showing that chromosome, one extra chromosome. Sorry, I'm scared to don't use that. So this extra chromosome is has many genes, and which is triplicated in Down syndrome. So when I'm talking about the genes, and that one chromosome from there is showing here in a long beak, and only one of those bands, you can see the number of genes I mentioned here, they are in a one single band because we have few hundred genes in one chromosome or in one band. So most important in there that we have a gene I showed you, red amyloid precursor protein, also known as APP. If you went to my other colleagues, Professor Holland's talk, he showed that this protein, APP, is produce amyloid, and amyloid is one of the cause of Alzheimer's disease. So Alzheimer's disease is characterized by two, was a neuronal dysfunction, leads to a progressive decline of cognitive function and development of dementia. But because the APP gene in chromosome 21, which is common in Alzheimer's disease and Down syndrome, could be one of the most important factors towards a dementia. So on the left, it's showing here that these are the amyloid protein make like a ring and is called senile plaque. This is a picture from a Alzheimer's disease brain, and I'm going to show some of our work in a minute. And there is another here is called neurofibrillary tangle. So the plaques is external, outside of the cells, and neurofibrillary tangles is inside the cells. So not only the amyloid and tau, they are the main protein. There are many genes and proteins present in chromosome 21. Some of them affect our immune system, and we have a strong innate immunity, and that also are not very same in Down syndrome. They are more prone to have a inflammation. So I'm going to share with you one of the gene from that big cohort, because I cannot show you all of them, but if anyone interested, there's many papers on that. So this gene called TRAM2, triggering receptor expressed in myeloid cell 2. So this protein is actually present in the blood, in the serum, and especially in myeloid cell, and it affects our immune system. On the right-hand side, I just showed that these proteins is cleaved, and one of the portion is soluble, and that circulate in our serum. And this protein is not in chromosome 21, is in another chromosome, chromosome 26, but most of the immune genes are very closely in linkage disequilibrium, which is we call HLA or MHC. So I do not have time to go through too much about this gene, but most interesting, just 2-3 years ago, it was found that if you have a mutation in this TRAM2 gene, you are more prone to have Alzheimer's disease. So we have a small cohort of 50 Down syndrome adults in our institute. So we try to sequence all these patients, and we found that we have 4% increase this TRAM2 gene in our cohort. So I'll come back a little bit later more about this. So this is again our own picture. So we have Down syndrome brain, this patient was seen long time ago, my colleague Professor Holland. So we have analyzed 20 brain from Alzheimer, 20 from control, normal healthy control, who are same age match, and 20 from Down syndrome. So if you see what I showed you last time, the plaques, and this is here in a Alzheimer's disease patient have a plaque, and this is one of the Down syndrome. So when you look their plaque, they look more or less very similar, although we can identify a little bit more which one is more dense or not. And on the left-hand side, you could see these are the normal brain. These are called neuron. And here is a part of the brain. You heard this morning the talk mention about hippocampus. So these are the hippocampus cells. And normal, healthy people, these cells are absolutely normal. But in Down syndrome or Alzheimer's disease, you can see these are forming the neurofibrillary tangles. And these are one of the culprits. And not only we have this, the APP or TRAM2, we have many genes which is affecting our immune system, and brain have different type of cells. So one of the type of cells is neuron, which I showed you that what happened to neuron, but we have another cells called microglia, and these are the cells take part clearing our dead cells and protect us from the immune system. And so here we could show that the protein around the plaques. So see, these proteins are coming very close to the plaque, maybe trying to save our brain, and sometimes they fail and make more dense plaque. So as I mentioned, the TRAM2, the protein actually is not inside the brain. Actually, TRAM2 more expressed in the T cells and B cells, which are immune cells, and myeloid cells. So this is one technique we identify. We just try to publish this work to see that we are first time we can identify the defect of this gene in normal or live patient. So we take their blood live patients, and we are trying to show that in normal case they have a very nice round structure, but if you have a mutation or defective, they are quite dense different. So now this could be one of the good biomarker we could show that how these cells are different. So we can give some idea what happening inflammatory changes in Down syndrome or Alzheimer, and maybe it could be a new biomarker of future. My colleague, Professor Holland, also showed that we have many new tools now. So we can grow the neuron and from the skin cells, from the iPS cells. And so these are the work, again, my student did it. So you can see these are normal, healthy neuron we grow in our lab, and then we give them different treatment and try to see what happened, that do our treatments can save them. We try to find different factors. How could we grow from skin cells and other cells to make them different type of cells? So this is the technique Professor Holland explained, and is well known now. It's a very, very famous way. So we grow all the different components. We grow the neuron, another type of cell called oligodendrocyte, which cover the neurons, then microglia on the left, which is I just showed in the inflammation, and another group of cell called astrocyte. They are the supportive cell. They pass all the nutrient and help the neuron. So this is the hippocampus neuron, which is the most susceptible to the Alzheimer's disease or Down syndrome. So we grew them, and we can show that how beautifully that neurons look like, but when they die, they become a clumpy and different structure. So we try to give, because inflammation is one of the cause of killing the cells. And we see that with the aging and Alzheimer's disease, we have more. 1 minute, okay. So we try to do this. We trying different therapeutic approach, giving them anti-inflammatory, some small protein, or as they call microRNA. And I have no time today to explain. We found many genes and proteins in iron related, and we're trying to dissect and see what we could find from this. So summary of my talk is that Down syndrome, you know, is aneuploidy due to chromosome 21. By the time the Down syndrome people reach age of 40, more than 60% Down syndrome develop dementia, but not all. Some of them do not have dementia, could be that is genetic factor, could be your, here our Indian population may be slightly different, we do not know. Maybe the environmental factor and other factor are helpful. We did found many other genes in immune system, but TRAM2 one of the very important one. We did find first time that yes, the mutation in TRAM2 in Down syndrome, and our aim, if we understand the molecular signaling, how this pathway working, then maybe it could be a novel therapeutic approach. Thank you for your, and these are the group of the PhD student, and here is our group in Cambridge on the right. And thank you for listening.
Thank you, Dr. Huma. I think it's a very important research, and in this day and time, and definitely these sort of research will definitely lead us to therapeutic endpoints, and where the cognitive improvements in Down syndrome will definitely improve. So a couple of questions, yes.
Anything can be done to increase amyloid production in Down syndrome patients?
Amyloid production. Yes, there is some treatment, drugs company trying called BACE and different type of immunization. These are very primitive stage. Immunization causes a lot of side effects, so they are not ready yet. None of these treatments. Yeah.
Is microRNA therapy ready now?
MicroRNA, as I showed you only one, in Down syndrome, not only amyloid, okay, there is other gene, the immune system one affecting, there is the ApoE. So which one you want? We can target with in the dish, we're targeting one. And yes, microRNA work in one in the dish, but we cannot just use microRNA in humans because maybe there is a new technique called CRISPR-Cas9. If we know one gene, one disease, we can. But when it's several genes, it will be difficult. So it's very, very early stage, but I hope it will be.
Thank you very much, Dr. Huma.
Thank you.
Thank you. Then we move on to the next session. Yeah. Call upon Dr. Namita Jacob to talk on ensuring quality in vision services.
Thank you. I think this is the first talk that's talking about vision at all, or hearing. It's occasionally a byline in many of the presentations. And this is really something that has worried me repeatedly, not just in the field of children with Down syndrome, but children with intellectual impairments. Because if I had gone to a conference of ophthalmology or pediatrics, they would tell you that at least 50%, 55%, 60%, depending on what
Maybe
you're
adjust the
counting,
mic, yeah.
we should expect that children have vision difficulties. The problem is that they are not disabled enough. And this is really something. If the child did not have already one clear, one visible, one overriding disability, there's no question that these children would have received a better quality of care. This is something that I've seen across. I work across different disabilities, and this is something that I've seen everywhere. This presentation talks about what we are trying to do, at least in Chennai, in one city, to address this problem. I want to tell you what we found, because although I see many of the children here with spectacles, I really wonder whether you had, in fact, the assessment you needed, the correction you require, the environmental support the child really should receive. So the data I'm presenting today falls within a larger project called iCount. And it started from this anger that I still feel in me when I come across this. Because even till today, India is home to some of, I think, internationally acclaimed eye institutes. So to find with L.V. Prasad, with Shankar Nethralaya, people come from all over the world to study in these institutes. The majority of the optometrists graduate from these institutes. The majority of pediatric ophthalmologists come from these institutes. So why? What is going wrong? I wanted everybody involved, be it parents, be it professionals, whatever your speciality or subspeciality is. I wanted that everyone woke up, and we picked the term eye count because it was a registry that we were creating, covering over 1,000 children in the city across all developmental disabilities, including Down syndrome. We wanted to do this because I really, as someone who is not in fact a vision specialist, someone working in early development, child development, vision matters, vision helps. Now, I'm somebody who starts most of my talks to ophthalmologists by saying being blind is fine. So I would say both, that if you are totally blind, this is okay. But if you're going to have vision and people around you understand vision, they can use it so effectively to support development. So why in this population, and that's the second I in the eye count, why in this population is it that the individual disappears when it comes to a child who has one diagnosed disability? The children with cerebral palsy, children with intellectual impairment, children with Down syndrome. Why is it so hard for people to actually do their job? So we've documented over a span of several years across children of different ages and across institutes in our city of Chennai. And at every big marker, 250 children, 500 children, we stopped, we assessed our data, and we went back into the field, taking the findings and educating everybody involved. We found that more than 50% of the group had visual impairments. This is the large group of developmental disabilities. Specific disabilities like cerebral palsy, over 66%. In the first 250 children across 4 of our premier rehabilitation institutes, we found that visual acuity or vision in general was simply documented as CSM or F and F. And what this means is that when I look at your eyes and I move something in front of it, you are looking at it and you are following it. And this is really not good enough, I'm sorry. CSM means when you're looking at something, your eyes are looking straight, both eyes are looking straight, they are steady, and they are able to stay sustained on the target when I keep moving between your two eyes. Also, good indicators, a good way to begin. But if that's how you're going to finish doing an assessment of my child, I don't agree. We realized that it's not just the medical community, it's not just clinical assessment, but in all these rehabilitation institutes where children we take with great faith that they receive the best rehab and best support, we found that more than 50% of the children had no accommodations, not even simple stuff like bringing things closer, making things bigger, using things that are good contrast, just common sense. Even common sense. You didn't use common sense with our kids. And we also realized that in those cases where parents knew there was something not okay, they were not quite sure what it really was. What was the problem? Now, looking inside the group of children who had a diagnosis of trisomy 21, we had 26 kids, and about 50-50 boys and girls. The youngest was a year old, a year and 2 months, and you'll see him coming up soon. The oldest was 20, almost 21. So most of the kids were school age, entering school age. One of the things that we saw in our group was that many of them had additional difficulty, and a lot of you have talked about these things, problems with their heart, problems with thyroid, endocrine issues. A lot of the children were low birth weight, a lot of the children were failure to thrive. And these are things that should already alert us as professionals, because we know that these are associated with visual difficulties and hearing difficulties, by the way. 23% of the group, which translates into 6 of the kids, had a diagnosis of visual impairment. And you'd think, well, 6 out of 26, okay. It's not okay, because of the remaining 20 children, or remaining 19 children, Only 2 had no additional vision concerns. All the other children, when they went through our thorough vision assessment, we found other visual issues, not qualified as per a clinician's examination for having a visual impairment, but certainly having difficulties in using their vision effectively. And that's really what you want to know as a parent, isn't it? Is there something going on? Is there something I can fix? Is there something I can fix by doing something with my child or by doing something with the environment? That's all we're really asking. So a lot of the issues are things that we would expect, that a lot of children, this is known in the literature very well, a lot of children with Down syndrome have myopia. So you'll see a lot of the children wearing very thick spectacles. So a lot of the problems that you see there are problems that we would expect. Strabismus, cross eyes, astigmatism. But these are all things that I would expect that somebody is fixing, at least with a pair of spectacles. It's something you fix for yourself as you grow older and you realize you're not seeing. It's something I always have in my hand. It's what we do for ourselves. How come it didn't happen for the children? Because in this group of 26, including the ones with a diagnosis of visual impairment, 6 of them had glasses. So although we saw this, it was clearly not being corrected in all the children. In addition, among the children, remember this is the list of children who went through a clinical exam previously and were found to have no visual impairment, right? But these are the children who have problems like nystagmus, kids whose eyeballs are shaking like this. Don't tell me we could expect that this child does not need visual support. So how does stuff like that get missed? When we began 2003-2004, the vast majority, 188 out of 216 children were recorded using CSM FNF, what we just talked about. And tools were actually used, like you go to an optometrist and they put up those little charts and tell you to read the E-chart and so on. Any kind of tool with our children, and let me tell you there are tools, but any kind of tools used with our children is 28 out of this big population. Since then, we had the good fortune to meet Dr. Lea Hyväärinen, who's an ophthalmologist, a Finnish ophthalmologist, who has a connected set of assessment tools that can be used with infants, it can be used with children who are pre-verbal, it can be used with all the way up, right? And they allow us to systematically check every area of vision, not just are my kids' eyes crossed, does my child need spectacles, but following vision all the way up to does he understand what he's seeing. And this is important. And this was fabulous, and I take my hat off to the city of Chennai for this. Across all professionals, people got together, learned how to use these tools, went out, found funding, got tools, and then you see the big change. Since 2005, more than 50% of the children assessed, we are able to get an actual acuity number, and this is a tremendous change. If you look across the 21 children, you'll see why I'm concerned. This is, again, the group of 25. 21 children, we were able to get actual measures on the kids using the tools. And instead, if you look at assessment from this perspective, you'll see that 6, 7, 8 children measured with Lea paddles had an issue. You'll see more than half the children, so 7 plus 7, 14 of the children had a visual impairment as defined by our Indian law today. The problem that we saw was that everybody said, he sees enough. That is, he looks at me and smiles. He looks and picks up a toy. He sees his food. He's walking. But the problem is, if you just helped him see a little better, you would see that he walks better, he reaches better, he reads better. A lot of things change. For those who think he sees enough for his needs is an adequate statement, I'd like to say that 7 of the children in this sample had an actual hearing loss. This in spite of 50% of them not being properly tested. And 3 of the 7 children had vision loss as well. So you have a child who has difficulty seeing, difficulty hearing, and neither of these things is actually addressed. So if you look here, you'll see we used speech as a primary way of interacting with these children, all the children, all of them, whether they were deaf or whether they were hard of hearing or whether they had vision issues. A few people used gestures too with the deaf kids, and a couple of them, including for children with both vision and hearing loss, used pictures. So it was no surprise that more than 50% of the children were considered having significant speech and language delays. The problem is how we behaved. It wasn't their problem. So essentially, if we want improvement in these areas of communication, of mobility, it has to do with whether we make the basic accommodations. This is the little kid, I said 1 year, 2 months. He had albinism. You'll see here motorically, he was just at supported sit at 1 year, 2 months. Given a target that was challenging for him with albinism to use something that's shiny, you can see in the second picture, the child has his fingers splayed, his tongue thrust. It's a sign of stress. Instead, when you replace it with something that's visible to him and appropriate to his visual needs, you'll see his body immediately, his tone is more appropriate, and he's actually with minimal support reaching out actively. And this is the change that I want to see in our population. This is the change that we try to make visible to our doctors, to our parents, and to our clinicians, our interveners, so that ultimately children receive the support that they need. We really hope that this comes. We work actively at Chetna Trust to create regular training programs. We create accessible reading materials for children, making them visible, making them clear. This is a library that we run in the city. So you see the first one, Arya stretched, and you can see that it's something she can touch. So we hope with all these materials that we run trainings across disciplines so that professionals work together to provide better services for our children. Thank you.
I think it's really very, very important and a wonderful task that you have taken, and really it improves the lives of children with Downs. And any questions? A couple of questions? Yes. Yes. Why you are running away? Yeah. She has got a flight? Yeah.
No, I realized I was over time.
That's okay.
My daughter is 5.5. She is wearing glasses of +3 lenses in both the eyes. And along with that, doctor has said that she is having amblyopia. From last 1.5 years, we are patching her alternate eye in both the eyes. In initial 6 months of patching, there was 2 lines she was shifted, she was reading. And since the last 1 year, I am patching regularly. It's almost like 29 days a month. And there is no change.
How long do you patch?
For 5 hours, around 4 to 5 hours.
And what does she do while you're patching?
She is writing also, she is watching videos also, and playing blogs and all other things.
Can we talk offline? Because
Yeah.
there's more than just
Yes.
Single.
correction that we need to talk about.
Okay.
I think you have to be in touch with experts like her to sort out your one-to-one issues. I think there will be a lot of difference if the correct way of handling is done. I think that improves a lot and makes a difference both to the parents and the kids. Yes.
Hello, yeah, ma'am. My child, she's 6 years old. Many times I have got her vision tested. And like since birth she had this number, but now she's 6 years, but she is not ready to wear her specs even for a single minute. Every time then we doubt whether she's being given right number or not. And yes, I know definitely she is not able to read nicely the far away things and even the nearer one, but not able to find a good ophthalmologist. So how to go and where? Delhi only.
So I think you
We have to.
no,
I think.
come to
We all
Chennai.
Delhiites have to plan
Come
now.
to Chennai for an initial assessment, and then the follow-up can be done online. Yes.
I think we
I
all
think
Delhiites
initial
have to go
assessment
there
can be
now.
done, and then you know where we stand, and then no. Then we will see. No, not necessarily. See, there is a place where no. There is a place where something starts. Then it will propagate to other places. So somewhere it has to start. So it has started, and then we will reap the benefits all over the country. That doesn't mean only Chennai will have everything. It's not like that. I think every state should have all these. Whatever we learnt I think it is our responsibility to bring in those services in our particular places by latching on to these experts. I think that should be our motto. Yeah. Yes, that's what I'm saying. So, yeah. So, you are the leaders to do all that change. So, you should bring the change. Yeah.
It took us 10 years to get Chennai to this point, and I'm still not happy.
No, but if parents are motivated, then you can make it faster.
So the point that I want to make is you cannot wait 10 years.
Yeah.
Right? So I think you have to separate these things in your mind. There is one issue which is every city should have good services. That's a long battle. There's another issue which is your kid, whatever the age is now, it's already late. So treat them as two separate things. Yes, we will address
Finish
that
now.
everything needs to grow. But yeah, if the answer is take a trip, then take a trip.
Yeah. Thank you. Thank you. And then we have one last session. I think I can call upon Dr. Gurjeet Kaur, because then we break for tea if it's okay with all of you. Yeah.
Services are there for our children in Chennai.
Yes.
So is it possible? Like
Yeah.
I'm basically from Delhi, but right now based out of Ahmedabad.
Okay.
So is there some kind of registration can be done and some days can be given? So in a group we can travel there in one place and get
Yeah,
all
definitely
the assessment
things can
kind
be
of things
organized.
can be done.
Definitely things can be organized that way. I don't think it's a big deal. I think we can plan out. See, these meetings are meant for these sort of plans and how we go about. So we learn that there are certain things which can be offered to children, and we see how we will be able to reach everybody. So we'll definitely be able to plan and do things. Yeah. Now I call upon Dr. Gurjeet Kaur, who is the Vice President of Down Syndrome Support Group in Chandigarh, and I call upon her to give the talk on the experience of prenatal screening for Down syndrome in her region.
Good evening, everybody. I thanks the organizers for giving me this opportunity, and this is very different now. Today, you from last like yesterday, we are all talking about Down syndrome, their management. Prenatal screening is totally different than management. It is a new era which is not in the healthcare system of India right now. So I am going to just talk about my experiences in the prenatal screening. What happened is, in 2002, Government of India released grant for prevention of disability to Chandigarh. And I had an experience of my postdoc in genetics from US. So I was given this task to work for prevention of disability. Then I moved down in India and I was like looking what is going on for prevention of disability as such. And same way I came across Chennai. Chennai was the only, I am talking about 2002, not like 17. It was in 2002, Chennai was working on prenatal screening. Dr. Suresh, prenatal newborn screening, that was for prevention of disability.
We started way back in 1996, prenatal screening for Downs.
And I visited Chennai for all this to see what is, because I was not knowing about what is prenatal screening, how we are going to do prenatal screening, newborn screening. And then I went to Chennai. Then Gangaram was also doing some of prenatal screening and newborn screening. And we started with prenatal screening in 2002. And this is my experience. Like with my experience, I realized that maternal and child health form the backbone of healthy family and is an essential package of reproductive health package. And when we found that around 7.6 million children are born annually with severe genetic or congenital malformation, and 90% of these are born in mid or low income countries. Why? Because there are no screening strategy in our healthcare policies, and today also we stand there only. There are no screening policies in our healthcare system. And birth rate, if we talk about it, is 17%, and around we can say that congenital malformation 1 in 50 and 51 birth per minute take place. So if 51 birth per minute take place, so it is like every minute one congenital malformation child is being taking birth in India. And we all know, I am not going to talk about this because we all know like what are genetic disorders, and we had a lecture yesterday and we have talked about genetic disorders. But the chromosomes are the key, and we know that there are 23 pairs of because we have to talk about prenatal screening, so I have to just touch that there are 23 pairs of chromosome in human body, and during like formation of egg or sperm, they are segregated, and 23 goes in egg if we talk about egg, and 23 goes in sperm, and they fuses to form a zygote. And what happened here is, see, when the ova is released in the fallopian tube, the sperm fuses with the ova and one cell is formed, which is the basic unit of human body, and it has 23 pairs of chromosome. And this zygote, it multiplies, and on day 8 it get implant here in the uterus. Now, if we have the number of chromosome, if we have more than 23, if we have 23 pair plus one extra chromosome, what we talk about Down syndrome, the trisomy 21, the 21 number chromosome is one extra in these children. So what will happen when this zygote get implant here? It is not normal. It is having one extra chromosome, that is, it is different than the normal zygote, and then when it grows, it is unstable. If we say हमने नींव रखी घर की और वो नींव ठीक नहीं रखेगी, ऊपर जितना मर्जी हम महल बना दें, वो stable कभी भी नहीं होगा, वो गिर सकता है. The same way this implant is not stable, and any day it can come out. This is called spontaneous abortion. So what happened in Down syndrome? 60% of spontaneous abortion take place, 20% stillbirth take place, and 1 in 1,000 survive. 1 in 1,000 implants, they survive and they grow as a fetus, and we have a Down syndrome children. Now, this is, earlier it was, we could not see these children as such, but now we are seeing all these children because earlier there were polio, other so many communicable diseases which were prevalent in India. Now the government has taken interest and control this communicable disease. So there is a demographic shift from communicable disease to this malformation, genetic disorders. So if government today also take interest, we can't get rid of all these issues what we are facing today. So government has to be knocked to help us for all this. So in worldwide, when we started with, we found there are two strategies: prenatal screening and newborn screening. Prenatal means that we can, during development of fetus, we can identify certain congenital malformation and birth defects. And newborn means that after the birth, within 24 to 72 hours, we can identify certain inborn error of metabolism, like congenital hypothyroidism, which is a leading cause of mental retardation. During development of this fetus in the mother metabolism support, so the fetus grow as a normal, and when it comes to its own metabolism, there are defects and it leads to congenital so brain defects and physical disabilities. But if we treat them timely, we can prevent these disorders. So there are prenatal and newborn screening. We can identify certain disorders during development of fetus. See, in 1933, it was identified that advancement of maternal age has a strong association with Down syndrome, and it was found that invasive procedures are available through which we can identify this disorder, but any invasive procedure has its risk of fetal loss, and also it was only subjected to it was like advanced maternal age leads to having association with Down syndrome. How many, like it was only 30% pregnant ladies who were above the age of 35, and if we talk about India, they are all like 20 to 30 is the age group where the first pregnancy. So we cannot talk about this invasive technique there, but there were Down syndrome children being born in worldwide. So we cannot just say that with the advancement it is a chance that, but we, in our practical knowledge, we have seen that at the age of 21 also, Down Down syndrome children are being born. So it was seen that scientifically it was found that there are certain biomarkers. These biomarkers are produced by the fetus. They travel from the circulation through the placenta into mother's blood. So by a simple blood test, we can identify these markers, and these markers have a strong association with Down syndrome. We are talking about today Down syndrome, so I will just focus on Down syndrome. These markers have a strong association with Down syndrome. Like if we talk about here in the pregnancy, like this alpha fetoprotein, it can be identified between 15 to 20 weeks of pregnancy, and there is some certain normal value. At 15 weeks there will be a certain value, 16 weeks there is another value, and it was seen that in case of if the chromosome number are different, these these biomarker, their value changes as compared to normal. So it was seen that alpha fetoprotein had association with Down syndrome. It not only had with Down syndrome, but it had with neural tube defect and many other complications which we are not going to talk right now. And it decreases in case of Down syndrome pregnancies. And it was similarly found that SCG beta is another marker which can also be identified between 14 to 20 weeks of pregnancy, and its level increases in case of Down syndrome. Similarly, estradiol, which its level decreases 25% in case of Down syndrome. So what happened in 1988, non-invasive prenatal screening test was identified, which is called triple test, including maternal age, alpha fetoprotein, SCG beta, and unconjugated estradiol between 15 to 20 week of pregnancy. Now, if we talk about 15 to 20 week of pregnancy, it is so second trimester advancement pregnancy itself has its impact on women, and again if we talk about all these disorders, it becomes very difficult. So it was need for some markers, early detection and management of pregnancy. So it was found that pregnancy associated plasma protein, which is a strong marker and is association which can be identified as early as 9 weeks of pregnancy, and it has a strong association, a decreased value in case of Down syndrome pregnancies. And free SCG now we could able to identify 1992 in the 9th week of pregnancy, and this was also used as a marker. Now we had a dual test which was called which included maternal age, PAPI and SCG beta. And it was also found that detection rate, what is detection rate is if we say 62% or 65%, that we are missing, we are able to identify from out of 100.
Yeah.
Okay.
Yeah.
So an ultrasonographic marker was also introduced, and it also had an association with Down syndrome, and it improved the detection rate. So dual test and triple test were identified, and now these tests are available in pregnancy. Dual test with the ultrasonographic marker has a detection rate of 90%, and it can be done as early as 11 weeks of pregnancy, and we can have a confirmatory test after that, and within 13 to 14 weeks of pregnancy we can be 100% sure whether the pregnancy is going to have a Down syndrome or not. So but we have to be very sure that these are screening tests, and the screening tests are different than diagnostic tests. They only, because we are trying to screen from the mother's blood, it is not that we are directly identifying the fetus. So there are a lot of parameters during calculation of this high risk, low risk. We have to be very sure whether it is a high risk, low risk, maternal, because sensitivity and specificity also matter. So there are various factors, whether diabetes, hypertension, there are some drugs given to mother, that all are going to impact on because it's the mother blood. So mother blood plus the fetal is going to combine, and these are going to have impact on the analysis part. So we have to be, critically we have to evaluate, because otherwise we will lead to false positive and false negative. False positive, that is normal test, then abnormal test but normal condition, which will lead to more and more testing, more more and more anxiety. We are going to counsel the pregnant lady that you are in a high risk group, what is high risk, now what to do next. So it will lead to lot of anxiety, and false negative is we are going to falsely re-ensure a normal screening test. So all these things have to be taken care before we divide the pregnant lady into a low risk group or high risk group. And once the low risk or high risk group is evaluated through biomarker, then the second step is ultrasonographic fetal soft marker, which have a strong association with these Down syndrome, and we identify and then we recalculate the risk, and then if subject to diagnosis if needed. So the prenatal screening is not only testing, counseling, it is testing, counseling, follow-up, management. Genetic counseling play a very important role, because when a pregnant lady come, what happens? I today at here I really wanted that the mother should be there, because this is like awareness speech. Like genetic counseling is very important. When we say, when a pregnant lady come, or we consider ourselves going as going to a doctor about us telling about pregnancy, what we will do? We will be so happy, we will be excited, we will never think about that our child is going to have some disorder which are going to be life threatening and which are not going to be cured. Never it comes to our mind, and it is we are happy that we are pregnant and now our family is going to extend. So genetic counseling plays a very important role. As soon as the pregnant lady comes, we give her a post-test counseling, we tell, but now again we have to know it is a stepwise process. If once she come and we tell everything what I am just talking to you, it will be like a mess of what is going on, what I have to do next, it will not be clear. So it is a stepwise process, and we have to go stepwise in a systematic way, so that in the end the couple can take their own decision about the pregnancy, because we are trying to identify Down syndrome here. And if we talk about Down syndrome, they can go in a developed country, people go for Down syndrome children, and because there is all support from the government, there is systematic evaluation programs, there are schools, there are strategies for development of the children, and so we cannot guide them that you should have the pregnancy, continue, or you don't. They have to take the decision. So genetic counseling play a very important role, so that it's their child, they have to decide whether they want to continue with pregnancy or not. But this is the most important, that during pregnancy they know that what outcome the pregnancy is going to have, so that they can take their own decision about the pregnancy. That is the best part. And I will just share my little experience. Can I take 2-3 minutes? Okay. Triple test. See, when we started with triple test, there was no awareness among professionals. They were not knowing what test, when to do it, nothing. They used to call us, oh, you are saying triple test, when we have to do triple test, when we have to send the pregnant lady to you. So we had to generate lot of awareness to the professional before the general public. And then when we started generating awareness, and secondly what we faced was, it was like test 15 weeks, the pregnant lady coming 15 to 16 weeks for testing, then first screen, then ultrasonographic, then confirmatory. So it was like advancement of pregnancy was there. 20 weeks, 15 to 20 weeks is a narrow window, and we were reaching 20 weeks and we could not counsel the pregnant lady properly. Secondly, it was like advancement of pregnancy, and we had to be very fast in doing all this analysis. So it was becoming little difficult for us, and then we again searched and we found that dual test is available, which can be done between 11 to 13 weeks, and it is having a strong detection rate. So we focused on dual test. When we started with dual test, in the first month there were only 2 pregnant ladies visiting our center, because in India after pregnancy, pregnant lady only come after first trimester. They generally visit, and it's a government hospital. There was no awareness. I'm talking about 2003, 4, 9. At that time, there was no awareness about these tests, and so we had to generate lot of awareness again about early intervention management. So we started with that, and we really worked hard for 1 year, and then what happened? It was so much pregnant lady coming in the first trimester. Now ultrasonographic became a problem because it was an ultrasonographic evaluation. A government hospital, one radiology department catering to the whole radiology department. So how to get this NT done? So it became again it became like what to do next. So again we searched about, and we started with contingent screening program, which is like segregating the biomarker and ultrasonographic marker. I am not going to take in detail, but there are various strategies available now, dual test, triple test, quadruple test, contingent screening, integrate screening. It has to our resources and infrastructure. We have to decide what screening strategies we are going to adopt according to our own resources. And we till 30th June we have screened around 35,165 pregnant lady, and we have picked up 14 Down syndrome in the during screening, and we missed 4 because it's a screening, so we are going to have some false positive and negative result. But very strange was that when we counseled these 14 pregnant lady about that, there are various in developed country you people go for Down syndrome babies. You should have Down syndrome baby. They are so good. Their IQ is low, not like they are mentally retarded as such. Their IQ, we gave them so much counseling. We tried to counsel them, but out of 14, nobody went for continuing of pregnancy. And moreover, when we talk about high risk, they start saying we don't need it, we don't want to go for confirmatory, we want to terminate. If there is a defect, what we will do? We cannot go to the hospital, because see, counseling, we have to tell them both aspects, positive and negative. What is available in India as such, we have to guide them, because we are counseling them, we are the guiders to them. So we have to give them both type of counseling, positive and negative, and then decision have to be there. So, and then the 4 which were follow up when we called after delivery, these 4 were also after we have done this triple test, we have done ultra. Why we had a Down syndrome baby? You have not done in a better way. So nobody wanted to have a Down syndrome child when we talked about them during counseling session. So it is now also it is a need of a coordinated and a comprehensive program. So when we were doing this, I came during genetic counseling, which is very important. Now we are working we are having a Chandigarh Down Syndrome Society. When I was working I started with prenatal screening, and when we started with we came across the ladies who had one Down syndrome child, and I saw their issues. So many issues were related to the first child. So we thought of formulating a Chandigarh Down Syndrome Society, and it is formulated with 2 objectives. One is prenatal screening, early intervention, detection, management, and second is if we have a Down syndrome child, how we are going to help that child for its better growth and development. So that are 2 objectives which we are going, and today I am here on the behalf of my Down Syndrome Society. So prenatal screening with this prevention-based approach and cost effectiveness is a long run in important for a healthcare system for a healthy tomorrow.
Thank you very much, Dr. Gurjeet. And any questions? I think with this, thank you very much, and we close this session and we go to the main auditorium for the awards distribution we assemble there by around 5. Yeah.